Our next speaker is Bailey Arruda, and Dr. Arruda is a diagnostic pathologist at the Iowa State Veterinary Diagnostic Lab. Her interests include infectious diseases in swine. Her primary experience is in pathology and pathogenesis and diagnostic assay development for infectious disease. Her current research focuses on atypical porcine pestivirus, porcine astrovirus type 3, and porcine circovirus type 3. Please join me in welcoming Dr. Arruda.
Well, hey guys, thank you so much for coming. I know your time is pretty valuable, so I'm going to keep this pretty concise, brief, and generally to the point. If you guys have questions during the presentation or something doesn't make sense, please let me know right off the bat. It's going to be decently short, so we'll have some time for some meaningful interactions, I hope. So I'm going to start with a story because facts really don't mean anything if you don't remember them, and people tend to remember and learn from really great stories. So start with the story of the great Masquerader. So there was this unusual disease being described in swine in about the 1990s. Started kind of in Canada and made its way down. In about 1994-ish, John Harding described a virus that was actually in the tissue of these diseased pigs and identified that as PCV3. Not until about the late 1990s did we start to see devastating epidemics in the United States as well as Canada due to this agent. But it wasn't until the late 2000s that we actually got effective vaccines on the market. If you go back into these samples, historical samples, it was in 1962 that they can actually detect PCV2 in populations where it ended up causing disease. And it looks like in 1985, there was actually sporadic disease in those herds. But that's a long time, from 1962 all the way to the 1990s while we started seeing devastating epidemics. There's many people that would postulate why that time frame. But I think a lot did change in the way that we raised pigs and the way that we integrated them into our systems between 1962 and 1990. So now we are much wiser than we were back then, and we understand that PCV2 can cause a wide range of disease, anywhere from PMWS and lymphadenitis to interstitial pneumonia, PDNS, pulmonary disease, as well as enteric disease. And not uncommonly does it cause reproductive failure in the form of mummies, right? So this next picture I'm going to show you, and I'm not going to really ask you to become a pathologist right now, but I'm going to point out some things I just want you to keep in your mind so that when I show you another picture, you can make a correlation between that. So this is the heart of a fetus. All that teeny tiny purple stuff in there, that's bad. You don't want that there. And all of this brown labeling here, that's PCV2. So here you have a lesion, a diseased heart in a fetus, and you have a virus replicating within that heart. However, despite all of these clinical syndromes that PCV2 infection can result in, a majority of these infections in pigs are subclinical, meaning you see a PCV2 pig in general, you're not going to be able to tell that he's viremic. So in about 2016, 2 papers came out and they started to described a new type of circovirus. In the first one, it was associated or detected in sows with PDNS-like lesions. It was also detected in the fetuses, mummies, and stillborns from those sows. Another publication came out, and it was talking about growing pigs. And again, this is what I'm going to tell you. This purple stuff right here, bad, 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 bad. This is a vessel in the heart, and it's surrounded by inflammation, which is purple. This is inflammation in the heart muscle. And then you have detection of PCV3 in the tissue that's diseased. So since these first descriptions, and I don't know if this is going to play, no, PCV3 has been detected on multiple countries and multiple continents. However, there's really no strong evidence provided by any of that data that would associate it really strongly with disease. So detection doesn't equal disease. So they're describing, hey, we found it in Siberia. It's the most recent paper I came across. Great, it's there. Let me know what's happening or what it could be causing, right? So how does PCV3 compare to PCV2? PCV3 strains are very similar. When you look at the ORF2, which is the capsid, which is what the body recognizes and responds to immunogenically, they're very similar in that they look like, it's like comparing a pig to a pig. So this is just a phylogenetic tree, and in short, the shorter these little legs are, the more closely related those strains are. So PCV3 is very different than PCV2. Very different in terms of genetics. It's kind of like comparing a cow and a pig. So if you look at PCV2 here, look how long that leg is right there. And that's about a 50% difference in the ORF2 between PCV2 and PCV3. So it's predicted that PCV2 vaccination, and based on our data, it does not appear to protect against PCV3 infection. So if you're going out to your herd and you're vaccinating for PCV2, you can't expect it to protect against PCV3 infection. So at this time, you have two pretty good papers that are saying it looks like it might be involved with reproductive failure or multi-systemic inflammation in growing pigs, but there's two papers. It was in 2016. We haven't heard much of anything meaningful since those two papers. And so a lot of people in the industry said, nah, doesn't, it is what it is. It's there, it's endemic, it's been there for a very long time, which it has. We don't really care. And as a diagnostic pathologist, I didn't really know on what cases I should be testing for PCV3. No idea. So you send a respiratory case in. Is that on my differential list? Should I drop a PCV3 PCR on that case? Could it be playing a role in this pig's disease? Nobody really had any good answers for when we should be testing or why or when it would be important to test. So we started to look at it a little bit more closely, and this is kind of your confidence gauge in terms of how important something could be. So if you're looking at consistent detection by PCR and an accurate case definition, which to me just means you look at a pig, it has diarrhea, that's watery, and then you look at the next pig and it has diarrhea that's watery, and the next one, there's your case definition. You have watery diarrhea in these three pigs, so that would be a case definition in that situation. And there's an absent or inconsistent detection of known pathogens. If you're submitting, for instance, that diarrhea case and you submitted those samples from 3 pigs, and we run a rotavirus PCR because they're 4 weeks of age and we get a CT of 12, that's going to tell me there's a lot of rotavirus there in that pig at that time. So it's talking about a high viral load in that pig. So there's an inverse relationship between the CT value, right? As your CT value goes down, the amount of virus that's there goes up. Repeat diagnosis, and then multiple sites affected. Absence of unknown viruses, as well as, again, back to that image that we just showed you with PCV2. If you have a diseased tissue and you detect an agent in that diseased tissue, then you're pretty close to having as high a confidence that you can that is associated with that disease without actually reproducing the disease in an experimental model. So we did some digging. We get a lot of cases from swine practitioners. We're the largest actually kind of swine diagnostic lab in North America, so we have a really great data set look at and to evaluate. It is biased. It is not completely accurate, and it will give you about 100,000 view of what's going on in the U.S. swine herd. Just as an aside. So looking at those cases that span this time frame, about 11 months, we had 22 cases that represented 36 fetuses or fetal groups, and commonly those will get multiple fetal groups in one case. So we'll get 2 or 3 or 4 different litters or different groups of fetuses. These originated from 20 different sites, from multiple different states. And when you look at the submission form, they'll commonly report an uptick in mummies and stillborns. If they noted a number, it was commonly 5%. And they'll also reference that gilts and low parity sows are more commonly affected. But if you are looking at averages, you miss things, right? So for instance, if you look at your herd and you're reporting about a 7.7 mummified fetuses per litter, and this is what your data looks like that generated that number, you can see that right there, those are a little bit outside of what you would be expecting. So you look a little harder, and you separate the sows from the gilts. And you see that, well, your gilts are here, or your sows are here, but your gilts are about 16 times more likely to have a mummified fetus. So really, when you're looking for a disease diagnosis, you commonly have to look at the individual litter or the sow. You can't rely on your production data necessarily to tell you that you're having issues. They may or may not be impactful productivity-wise, but that you're having disease issues if you're just looking at your averages. You got to go to the tails. You got to see what's going on in subpopulations. And I ask you guys, what do you think is normal number for mummified fetus in a litter? Anybody have a number where they start going, If I'm walking a barn and I see 1 in a litter, okay. I see 2, I get a little bit more concerned. If I see 3, and this is just a rule of thumb, if I see 3, probably something's going on in that litter, right? Herd-wide, I don't know how impactful that is, but in that litter, it looks like there's an issue. And then what is the acceptable number for mummified fetuses in a herd? I'll tell you, talking to people with and without this problem, their mummified fetuses in the herd varies significantly. Some are okay with 2%, some are okay with 5%, some are okay with 15%. It seems like it just is based on their historical record, right? So what we got from you guys and practitioners was mummies in the same and different litters as well as stillborns. And the crown to rump length was about 7 centimeters to 30 centimeters in those guys. So based on the crown to rump length, you can estimate when in utero death occurred. And so anywhere from 45 to 70 days, those guys were dying in utero. The PCV3 PCR that we ran, it was commonly detected in multiple litters per group. For instance, they submit 3, it's detected in 2 of those 3 fetal pools. The CT values varied anywhere from 9.4 to 34.4. Now in the cases where it was a 34.4, there was multiple groups submitted, and those CTs in the other groups were commonly in the 15s. So commonly the CTs are anywhere between 10 to 20. But if you look at those CT values, and like I was telling you with the rotavirus at a CT of 12, there's a ton of virus there, we can actually do a calculation to tell you about the genome copies that you have in that sample. So at a 9.4, you're looking at about 1 trillion genome copies of that virus per milliliter of tissue. So there is an extensive amount of virus within that fetus. A fetus shouldn't really have virus in it. It should be pretty sterile. So looking at that sample type matters. Fetuses, PCV3 is not normal microbiota for a fetus. And if you look at the 20s, you're looking at about 1 billion of genome copies per mil in those fetuses. When we looked at other causes of reproductive failure in swine, All the PCRs were negative for other known agents. Bacterial culture, we got no significant growth. We also took a subset of these fetal pools and subjected them to next generation sequencing. So if you're looking for PERS, you target PERS with some primers and probes that amplify the genetic material of PERS. If you're looking for SIV, it's the same thing. You are already targeting that bug for detection by PCR. In next generation sequencing, there is no target, supposedly. It amplifies all of the genetic material, including the host, in an unbiased way, so that whatever is there, it should be able to detect. So we subjected 14 or 16 pools to NGS, and in 14 of those pools, we only found PCV3. In 2 of them, we found torcotinovirus, and then the other one, cytomegalovirus. So this looks very similar to the PCV2 picture. If you guys remember, this is the heart of a fetus. There's these purple dots, again, not good. Inflammatory cells within the heart of this fetus, right? If you look at this is PCV3 in situ. All this brown stuff, that's PCV3 replicating in the heart of that fetus. So what do we have? We have a diseased tissue and we have detection in situ of an agent. So our confidence that this is associated with this is about as high as we can get without reproducing the disease. Then a lot of people ask me, well, what's the impact compared to PERS or porcine parvovirus or PCV2? So what I did was I looked at our data set in between that time frame, and I took all cases that had fetal tissue PCR with a CT of lower than 30 and a singly detected agent. So all of these PERS cases, there was only PERS detected in that case, right? One little stipulation here, though. Not all cases are tested for porcine parvovirus. Not all cases are tested for PCV2, and during this time, for sure, not all cases were tested for PCV3. So you can't look at these numbers as absolutes. You have to look at the percent positive out of the cases that were tested. So percent positive PERS cases that met that definition was 11%. Porcine parvovirus and PCV2 were 5%, and PCV3 was 13%. So the percent of positive cases tested was high in PCV3 compared to the other 3 etiologies. So is it important in reproductive failure? Well, it really looks like it is, right? You have a high viral load, trillions of billions of copies within those fetuses, those mummified fetuses and stillborns, and you also had it in repeated litters and repeated submissions for multiple sites. There's no other common or known cause of reproductive failure, right? They didn't have PERS, they didn't have PCV2, they didn't have porcine parvovirus. And we couldn't find anything else other than PCV3 using next generation sequencing. And finally, we have a lesion and we have the agent in that lesion. So it's strongly associated with mummies and stillborns. We could not find any evidence when we looked back at our data set, which again is composed of submissions from you guys, that it's associated with abortion. So if you're telling me my sows are aborting at 30 days gestation, 35, 40, 50, I probably wouldn't request a PCV3 PCR off the bat because we just haven't seen that association. So reproductive failure with mummies and stillborns is distinctly different than an abortion. So perinatal infection, this is pretty uncommon based on our data set at least. There was only 3 cases. They came from 2 different sites. They were reporting weak-born and or abnormal piglets. And you can see that even in these guys, it was actually lower than some of the fetuses. So in their brain, they had millions to trillions of copies of PCV3. This is, again, the most uncommon presentation that we have at the diagnostic lab. So this is the brain of a piglet, of one of those piglets. This is a blood vessel. You can see the red blood cells. Around here, there's just too much purple. Again, inflammatory cells in the brain of this fetus, or of this neonate, sorry. They were 1 day old, 8-day old, and 10-day-old piglets. There's a foci of inflammation again in the brain. And these are consistent with a viral infection. These lesions are consistent with a viral infection. And then we have PCV3 actually replicating in a neuron in the brain. The other case, again, it seems like PCV3 might have a proclivity for the cardiovascular system. We have the heart. We have too much purple around these vessels, and we have too much purple within this muscle. So again, inflammation in the heart of these neonatal pigs, as well as PCV3 replicating. Final case was the combination of the two. We had inflammation in the brain, we had inflammation in the heart, and we had PCV3 in both locations replicating. So a pretty strong association there, as well as reproductive failure. When you look at growing pig cases, these are just my cases, so it is only a subset of the data that we have available. But I saw 12 cases, which I've been in the diagnostic lab starting 2014. This is obviously starting in 2018, so in 4 years. But I don't ever remember having cases where I could not explain this. It's a very distinctive lesion, and I'll show you the images, but I don't remember prior to that having cases with these lesions that I could not explain. So we have 12 cases from 10 different sites, and very interestingly, 5 of them came from the same sow source. So it seems like multiple pigs, at least from that sow source, were affected despite the fact that they went to different sites. So age range is 3 to 10 weeks, but they're commonly 4 to 6 weeks of age. This is, again, if you think back to like PCV2 and PCVAD, this is early compared to when we would expect a majority of the PCVAD cases to be occurring in growing pigs. The clinical signs varied based on the submission form. Really, we don't have an accurate, good case definition. So if you say, I want to go see if I have PCV3 in my growing pigs, I'm not entirely going to be able to tell you which pigs to pick. If you say, I want salmonella, I'll say, find your wasting pigs that may or may not have diarrhea. Submit some large intestine. But I can't tell you the same thing with this, other than they're picked by you guys and the practitioners because they don't look good. They're abnormal for what you would expect the adjacent pigs to look like, right? Lesions at the cellular level are very distinctive. I'll show you that. There's no notable gross lesions in those guys that are consistent across the cases. And the PCV3 PCR really isn't all that impressive. It's in the low 20s. So no good clinical case definition, and we don't know the percentage of pigs that are going to have this in an affected farm. For instance, if you submit a pig and I say, well, it looks like you have some inflammation surrounding the vessels of the heart and it's likely due to PCV3, I can't tell you. You could expect about 10% of your pigs to have this same lesion, or you could expect 1% to have this lesion and be affected by it. So this is the very distinctive lesion. So this is the heart, this is a vessel, and this is, again, too much purple. All those are inflammatory cells surrounding that vessel. Same thing here, too much purple. And then again, you have PCV3 replicating in the smooth muscle of those arterioles there. So point, counterpoint, it's been a bit of a journey in the last year, and I think we're getting there, but this is what I heard a lot when I was on the phone with people. It's been around for decades. We do, but we don't know at what prevalence. We also have a very dynamic herd, and the infectious status and the immune status of our herd changes over time. And that can really impact the expression of disease specifically from endemic agents that we've had and previously had immunity to, where we didn't have such a pyramidal system that we're working with now. There are numerous cases that we see in the past that had PDNS and reproductive failure without a known cause. at the time. So I think it's pretty safe to say it's endemic. And yep, but so is Rota, so is Strep suis, so are a lot of big hitters. And they just cause disease in a subset of individuals due to identified risk factors, right? So I like a lot of evidence to support what I'm saying. So here's my evidence. Lesion, bug and lesion, replicating. Lesion, bug and lesion, replicating. Lesion, bug and lesion, replicating. So you have PCV3 on your farm. And it can be detected by PCR in multiple samples. We commonly do all of these sample types at the diagnostic lab for PCV3. Processing fluids, serum, colostrum, tissues, feces, nasal swabs, and oral fluids. It can be found in any of those. However, I'm going to tell you again, just like I told you before, detection does not equal disease. There's no association, necessarily causation. So I can tell you when you find it there, it's there. But now what are the implications of that? Well, it's going to depend on your case definition and your clinical signs. What sample type did you use? I'm going to tell you a fetus at 20 is probably going to be different than saying you have a growing pig with a PCR of 20. Those are, to me, the interpretation of that is different based on your sample type. Or even processing fluids. You have a CT of 20 in a processing fluids, but you have a CT of 20 in a fetus. Sample type and interpretation of that sample type matters. You can't, processing fluids don't equal serum, don't equal a fetus. The viral load. Again, what's your viral load? Are you looking at a 34.4 in a fetus? I don't know what that means. Even if you're talking PERS or you're talking something else. It's not there at really high levels or at what we would think would be biologically significant. Diseased tissues. Are there lesions associated with when you found it? So processing fluids or oral fluids, I would say you have it. Probably it's not helping. However, we don't really know how much it's hurting. Productivity impact is yet to be determined. We just don't know. You're probably going to need additional info or data to try to determine what kind of impact it's having. So again, back at this. Mummified stillborn fetus, less than 25, probable. Less than 20, highly probable. So prevention. Guilt acclimation, since we're seeing since the majority of cases that we would see at the diagnostic lab are we're seeing fetal wastage in the form of mummies and stillborns, you could speculate that perhaps guilt acclimation would help you. How? I don't think we really have a really good idea of how to best acclimate gilts for potentially anything other than PERS, because acclimation actually at the gilt level is more than just PERS. We have to think more broadly than just PERS when we're acclimating gilts. PCV2 is transmitted close contact by like a oral nasal route. I would speculate that PCV3 is probably transmitted in the same way. When we've inoculated pigs, we give it to them IM, so you can get viremia via that exposure. When should you do it? We don't have a lot of information in terms of natural infection and the duration of viremia. So you need to leave plenty of time between exposure and breeding. If you're going to expose your gilts, you need to leave plenty of time. Viremia appears on very limited information to be greater than a month. So you really don't want them to be viremic at the time of breeding. That probably wouldn't be good. Vaccine, a few companies are working on it. One is currently available. If you talk to producers or practitioners and producers that are using it, they seem to like it. But the efficacy, as demonstrated by using vaccinated and controls in comparison to like how many reproductive failure cases they have or the impact on their productivity, that data, to my knowledge, really isn't currently available. So submission, if you're looking for reproductive workup, you need to be seeing mummies. And I would say select 3 litters And you don't have to find litters all at the same time. I don't care. You can throw the mummies and the litter in a freezer. And when you have 3, submit them all at once if you want. I would define an affected litter as 2 to 3 mummies and stillborns, and then submit 4 to 6 fetuses from each affected litter. So the importance of PCV3. It's a pathogen of pigs. It causes clinical disease in a subset of pigs that affects similar to PCV2. It does not appear to cause enteric disease as of right now. It does not appear to be a primary respiratory pathogen of pigs, and it doesn't seem to cause PMWS like was described for PCV2, meaning you go to a farm, you see a pig that looks healthy, and then 5 days later you can watch it waste in front of your eyes. It doesn't seem to be doing that. However, some of the practitioners out there that have had experience with PCV3, they say that it seems to have an impact on how hard they start. So they might not start as well as you think they should. So we have no real great answer other than it does seem to be causing fetal wastage in the US swine herd. When you're looking at the impact in an industry-wide view, it does not seem to have the impact that PRRS does. When you're looking at it in terms of case numbers, it certainly doesn't seem to have the impact that influenza has. So next steps, serologic assay development. This will allow us to understand the infection dynamics, how to prevent and control disease, monitor interventions. So in order to get vaccines that have proven efficacy, we really do need a model of disease to prove efficacy there. So the meat and potatoes of this presentation, what is it? It's a virus. It most commonly causes, based on diagnostic submissions to us, mummified fetuses, similar to like parvovirus. How do I know if I got it? Submit, as previously outlined, in terms of you want to see if it's causing fetal wastage in your herd. How do I treat it? Unfortunately, you probably can't. How do I prevent it? You can probably institute gilt acclimation or the vaccine. Do you guys have any questions or comments? Insights? No? Yeah?
You had on there next steps to reproduce the disease. Have you made any attempts to do that?
Yeah, so it's difficult to find, from my perspective, I think that it's unlikely to be able to produce the periarteritis or the inflammation in the growing pig. I think that probably a vast minority of pigs develop that lesion. So if you're looking at an inoculation trial, you'd have to have a really decently large number of pigs to do that. I don't know that for sure. In one study, when we did do it, we didn't see any significant lesions. So from my perspective, I think it would be great to have a sow reproductive model, because that does look like it is the most consistent clinical syndrome we're seeing with PCV3. It's hard to find negative herds. You can find negative animals by prototype ELISA, and you can find a bunch of them, especially if you look at the gilts, at the gilt pool. So you can find those and try to grab them before they get exposed. But again, you're using gilt in a herd that's positive, so that's a little risky too. So.
Have you tried to do any high-level analysis of associating your high CT values or your extreme disease with the genetic sequence and looking to see if there's any sort of association, to see if we're starting to maybe see a selection of a certain genotype that's going to become more, you're going to pop like in PCV2?
So for PCV3, the ORF2 sequencing, it's all like 98 to 100% similar. So they're all very closely related. When we did do analyses on these cases, we had I think PCV3 is in like three different, like it's A, B, and C. And so we had A, B, and C in all of those cases that we did ORF2 sequencing on. So it looks like the genetic differences don't necessarily impact the clinical syndrome that PCV3 was associated with. Good? Okay.
All right, let's thank the speaker one more time, and then we're ready for a break.